Assalamu alaikum. Good afternoon, everyone. I'm Meshari, Intervention Fellow for Bir Sultan Cardiac Center. And I'd like to thank the committee for their invitation to be presenting today here at the GIS. I'll be presenting the navigating danger iatrogenic left coronary dissection during anastomy evaluation. So, iatrogenic coronary artery dissection is a rare but a serious complication. While a small, stable dissection may be observed and treated in a conservative manner, the flow-limiting lesions or dissection require immediate stenting to see the entry point and to prevent propagation and occlusion. Our case is about a 67-year-old female with a known history of diabetes who presented to the ED with a chest pain, admitted as a case of anastomy based on a biomarkers, clinical picture, and a bedside echo suggesting a reduced LV function of 30 to 35. Patient was booked for a coronary angiogram, and as you can see upon engagement of the right system, it showed a right small non-dominant system, and if you can see at the non-selective view in the back that there is a tight proximal LAD lesion, which led us to proceed using an EBU 3.5 guide. My apologies, I don't have the time, the first angio at the time of engagement, but at the time of engagement, then due to the lack of coaxiality, there was a complete loss of flow to the LAD, which led to cath lab emergency protocol activation, which is a part of calling a second-hand interventionist in the room, extra hand of nursing staff, cardiac surgeon alert, and anesthesia. Fortunately, we managed to wire through the LAD, and we found the true lumen, and we stented proximally with distortion of almost 70% of flow to the LAD, but at that point, the patient blood pressure started to creep up down, which led to the second operator interventionist inside the room to use right femoral access to insert an intra-aortic balloon to stabilize the situation and buy us some time to proceed with our intervention. The distal flow in the LAD was noted to be TIMI1, so we proceeded with the distal stenting overlapping with our previous stent or proximal stent. And as we know from the first non-selective that we are dealing with a dominant left system, so conduction abnormality developed. So we needed also, as you can see here, to insert a temporary pacemaker to control that conduction and optimize a bit the hemodynamic, and that we can proceed with our intervention. Here, it was not clear, is it a left main, a short left main, or a separate ostium vessels of the LAD and circ. So we did an IVUS, which supported our motion that we are dealing with a separate ostium vessels. That's why, and the IVUS also gave us another hint that there was an involvement of the ostial LAD of the dissection flap. So we proceeded to stent a third stent deployed to the proximal or the ostial LAD, as you can see here in this picture. And if you can see from the cranial view, there was a hematoma compressing the flow, the proximal flow to the circ. So we decided to proceed with V-stenting strategy. So we took the wire out from the circ and we recrossed again to make sure that we are in the true lumen. After that, a stent was passed to the proximal circ and deployed with the flow or the proximal circ lesion improvement and resolution. Here is a coronary angiogram showing the flow in the cranial view in the LAD, and as you can see, there was a complete restoration of the flow to the LAD. Here, there was a final optimization of the stent in the proximal LAD, just in the case of longitudinal stent fracture. After that, we end up kissing. Before the stent optimization here, we did kissing balloon inflation, and this is our final angiogram showing resolution of the lesion, the proximal circ, and restoration of the flow to the LAD. So after the LAD stenting, the patient hemodynamic improved with a single anotrope support, and after setting the circ, the conduction abnormality resolved, leading us even to rule out to take the TPM on the table while the patient is still in the cath lab. Patient was intubated at that time, but sure, she has to stay in the CCU in a critical but stabilized condition. Within 24 hours of that event, the patient was successfully extubated with no pulmonary edema, and the intra-aortic balloon was removed, and with clinical improvement, and patient discharged home in a couple of days. So take-home messages, as mentioned earlier, coaxiality is an important step. Safe engagement is the first step in coronary angiogram. Since prevention is better than cure, always ask for help and utilize your surrounding in times of complication, and keep a clear mind for the need for devices, intra-aortic balloon, IVUS, and TPM. Multidisciplinary approach helps in management of procedural complication, including notification of shock team, activation of a cath lab emergency code that includes nursing staff who will be prepared for procedural changes. Before stenting, always confirm that you are the site of the lesion and make sure that you are within the true lumen. This case points out the complexity of managing catheter-induced complication, high-risk patient, and underlies the importance of multidisciplinary care. Thank you.
Excellent.